I am Nancy Anderson from the University of South Alabama, presenting my Doctorate of Nursing Practice Quality Improvement Project, a clinical practice lifestyle intervention for type 2 diabetes. Diabetes affects over 29 million people in the United States, about 12% of the population, and is responsible for more than $245 billion in health care costs annually. 75% of adults with type 2 diabetes are overweight or obese, which further increases costs. Lifestyle interventions targeted at 5% weight loss in adults with type 2 diabetes have been associated with reduction in cardiovascular risk, decrease in medication use, and lower overall health care costs. But less than 42% of healthcare providers effectively address weight management lifestyle interventions during the office visit, citing a lack of time and a skepticism that such discussions are effective. Yet, most patients at least attempt weight loss when advised. Weight loss achieved through lifestyle changes has been positively associated with enhanced self-efficacy in patients with type 2 diabetes. Furthermore, boosting self-efficacy through lifestyle change may contribute to downstream overall health benefits. Lifestyle changes are the most cost-effective approaches in the management of type 2 diabetes, but healthcare providers lack effective evidence-based models that guide weight loss interventions in clinical practice. Therefore, this project aims to initiate a brief weight management discussion during a routine office visit with selected patients and to provide supportive follow-up through weekly telephone calls. The research question on which the intervention is based asks, can a clinic-based lifestyle intervention directed at overweight patients with type 2 diabetes increase diabetes self-efficacy and lead to a clinically meaningful weight loss? Participant selection criteria include patients scheduled in the clinic in January or February to allow completion of the 3-month intervention prior to the end of the semester. Participants must have a type 2 diabetes diagnosis, a BMI between 25 and 34.9, telephone access, and agree to participate. Additionally, participants must agree to set and keep a 3-month follow-up appointment. The goals of the intervention are threefold. 1. To increase the number of clinic-based, detail-oriented lifestyle discussions by 20%. 2. To improve participant diabetes self-efficacy. And 3. To attain a clinically meaningful 5% weight loss in participants. The method used to achieve the first goal, an increase in the number of clinic-based lifestyle interventions, included identifying an office champion, as she has a critically important role in supporting the quality improvement process. The office champion advocates for the project and helps the healthcare provider prioritize the intervention in the practice. A chart audit was conducted prior to the intervention to assess how many patient records had documentation indicating that a significant lifestyle intervention discussion had occurred. A 20% increase from baseline was established and achieved as measured by a post-intervention random chart audit. To assure that appropriate patients were identified, charts were screened and alerts set in the electronic health record. To improve diabetes self-efficacy, the second goal, pre- and post-intervention diabetes self-efficacy were assessed using a validated tool. The lifestyle intervention was delivered briefly, simply, and succinctly during the scheduled office visit, and a follow-up telephone schedule was established and kept in a file at the practice, coordinated by the office champion. Changes in self-efficacy were measured by the Stanford Diabetes Self-Efficacy Scale, a validated tool that was originally developed in Spanish for diabetes self-efficacy. The 8-item scale has an observed range of 1 through 10 and an internal consistency reliability of 0.828. The tool is provided by the Stanford Patient Education Research Center and is free to use without permission. One of the 8 items on the scale is provided here and asks the participant, how confident do you feel that you can choose appropriate foods to eat when you are hungry? The respondent chooses an answer between 1 and 10, with 1 indicating not at all and 10 indicating totally confident. The participant must understand that a 5% weight loss goal decreases the cardiovascular risk associated with type 2 diabetes. The individual weight loss goal should be provided in written format and clarifies goal number 3 of the intervention. The American Diabetes Association Create Your Plate method was provided in addition to the ADA guidelines for physical activity, along with a list of helpful websites. An example is provided here using a patient with a present weight of 220 pounds, of which 5% is 11 pounds. His goal weight is thus calculated to be 209 pounds. Again, the patient should be engaged in this process, rationale provided, and adjustments made to meet individualized needs. Much like a medication prescription, so too should this weight goal be provided in written form. The plate method suggests a 9-inch plate filled half with non-starchy vegetables, 1/4 starch, and 1/4 protein. A list of these foods was also provided. The key to keep the approach simple and provide the patient with support. The ADA guidelines include 150 minutes of weekly physical activity divided over at least 3 days, with no more than 2 consecutive days without activity. The term physical activity was used instead of exercise. Additionally, participants were advised to limit sedentary time to no more than 90-minute time periods. While resistance training is a component of the ADA physical activity guidelines, it was not emphasized in this intervention in an effort to keep the approach simple. A list of free helpful websites, including fitness and calorie trackers, was provided to the participant in written form. In summary, a 5% weight loss goal was calculated and the ADA plate method and physical activity guidelines were provided along with helpful websites. Importantly, participants were telephoned weekly to provide support and assess progress. To summarize the methodology applied, an office champion was identified, charts were screened, and alerts set to identify appropriate patients. Handouts were developed to direct the discussion. Pre and post weight and diabetes self-efficacy were measured and compared, and participants were telephoned weekly between their 3-month office visits. If they were not available, a message of support was left with instructions to call the office with questions that they may have. And finally, outcomes were tracked and reported. A paired samples t-test analysis was conducted comparing pre and post diabetes self-efficacy scores. Paired samples t-test analysis was also conducted comparing pre and post intervention weight. Additionally, the percent of participants who lost weight and the percent of weight loss achieved was also assessed. The results are reported as follows. 89%, or 17 of 19 participants, reported improvement in diabetes self-efficacy. The mean of the pre-intervention diabetes self-efficacy score was 6.28 with a standard deviation of 1.51, and the mean of the post-intervention diabetes self-efficacy score was 7.63 with a standard deviation of 1.35. A significant increase in diabetes self-efficacy score from pre to post-intervention was found with a p-value of less than 0.01. Participant diabetes self-efficacy pre-intervention score of 6.28 and post-intervention score of 7.63 is shown here with a significant increase demonstrated. 68% of participants lost weight. The mean pre-intervention weight was 194.84 pounds with a standard deviation of 23.84, and the mean post-intervention weight was 192.77 pounds with a standard deviation of 23.94. A significant decrease in weight from pre to post-intervention was found with a p-value of less than 0.05. Of the 68% of participants who lost weight, the mean percent weight loss was approximately 2.04%. This graph demonstrates the frequency of which participants lost between 0.5% to 4% of baseline body weight. To conclude, The clinic-based lifestyle intervention that incorporated telephone follow-up support significantly increased diabetes self-efficacy in overweight patients with type 2 diabetes. Additionally, a significant weight loss was achieved by most patients, although it was less than the 5% goal. Limitations of the intervention include the small sample size and the short intervention time period. Given more time, the increase in diabetes self-efficacy demonstrated suggests that a higher degree of weight loss could be attained. Additionally, the impact of diabetes medications was not considered. Efforts should be made by healthcare providers to prescribe diabetes medications that are weight-sparing when possible. Importantly, commitment of the healthcare entity in identifying an office champion is necessary in order that the intervention process is sustained. Additional resources such as certified diabetes educators, dietitians, and diabetes support groups, although not a component of this intervention, should be incorporated when available. The results of the quality improvement intervention add to the evidence that remote support increases self-efficacy, which is associated with improved diabetes outcomes, including weight loss. The literature suggests that the frequency of telephone contact is directly related to the degree of weight loss and that the educational background of the person providing the remote follow-up does not matter. Therefore, the medical assistant and case managers should be trained and integrated into the process. Every effort should be made to promote the importance of lifestyle interventions in diabetes self-management, keep the process simple, provide routine follow-up support, and incorporate all members of the healthcare team. Special thanks to Dr. Ellen P. Moore, my faculty advisor, Dr. Yancey Holmes, my preceptor and physician mentor, Angela Abrams, my medical assistant, and Jean Holmes, the office manager. Without these individuals, the Quality Intervention Project would not have been possible.